Hi guys. So I'm super excited to be working with Becki again and speaking for them. I had the opportunity to speak with them earlier this year when COVID started, talking about some protocols as far as going back to work, and then after going to work, I lectured. So if you guys are coming back and listening to me again, I really appreciate you attending my course again. And like she said, today we're going to be talking about the proficiency and hand instrumentation for scaling of root planing. And first, I'm just going to introduce myself just a little bit. I am a dental hygienist. I have been practicing dental hygiene for 18 years. And currently my role is very vast. I am very busy. I've been working over the course of the last year, starting a bunch of new things and doing a lot of things with dental hygiene. I found that this profession has really given me the opportunity to do lots of different things. But like I said, I'm a wife, I'm a mom, I'm an educator. I'm a clinical dental hygienist working currently between 2 to 3 days a week. I lecture here and also internationally. Most of my international lecturing occurs in Japan. I do program coordination where I bring international students to the US and provide education for them on different things. Our one course that we're really known for is providing implant placement using cadaver heads. It's a very interesting course and I love being a part of it. I'm always a student. I'm always about learning, and when I got introduced to LM and Plan Mecca, I had the opportunity to go to Sweden, and I'll talk about that a little bit more for a week. And I attended a prevention dentistry course. I'm an innovator. Some of you may or may not heard of the eProp. I invented that product back in 2002. Currently, it is owned and sold by Practicon. I am a Chief Executive Officer of US Dental Express, and this is a company that provides GBR products for dentists to Japan. And then most recently, I have become the ErgoFinger US representative. I help market, promote, and distribute the ErgoFinger. I'll talk about that a little bit more. And then the research coordinator and a consultant. And research coordinator in our clinic, we are a research facility. We work with IMEC and we do research in our clinic. So I am super, super busy. But last year I had the opportunity to travel. I was able to go to Boston. I went to Sweden, like I said, and I took a course and was able to work with some of my students that I had spoke with back. All the classes that I have taught, we went to Sweden and we took this course together. It was really an amazing time. I was in Japan in March before the pandemic hit. And then in last November, I had the opportunity to go to Israel and do a course on GBR and using Ossex products. And it was an amazing experience. And like I said, as a dental hygienist, I think that my opportunities in my career has just really, I have been super, super lucky. So that course in Malmo, I was introduced to the LM representative out there and introduced to some of their new dental hygiene instruments that they offer. And since then, I purchased the instruments and have been using them in our clinic since then. And so I've had the opportunity to really get used to them. So currently I work 2 days a week in a perio clinic. I work for Metro West Orthodontics and Periodontics. We just recently built this new facility last year. We moved in December. And as you can see, this real quick tour of the clinic, we have 7 operatory rooms. We are a specialty clinic specializing in orthodontics and periodontics. Our clinics and our operatories are closed spaces, confined spaces, which doors on every operatory. And at the time when this clinic was built, Dr. Miyamoto believes in giving your patients privacy and creating a really good environment for you to develop your relationship with your patients. It just turns out it ended up being perfect for the current situation that we are in. So I work for Dr. Miyamoto. You may or may not have heard of him. He speaks all over the world in the country. He's very well known. We work with Dr. Michael McGuire. And I've had the amazing opportunity to work for him for the last 7 years. He really does everything to provide the ability for his employees to grow. Most of the staff that we have in our office are actually not people who have had previous training in dentistry. He believes in skills can be taught, but personality and who you are as a person is what's more important. And so I really have to say that I am so blessed to have the opportunity to work in his clinic, and for the things that he's done for allowing me to grow. So the key points of the lecture today are going to be about periodontal disease. I'm not going to tell you, oh, let's talk about periodontal disease. We're all hygienists. We know what periodontal disease, but we're going to look at it just at a little bit different angle. I think that I had the opportunity to listen to Sam Lowe. He came to our clinic and taught the laser, and he spoke about it a little bit differently. And so that's kind of what inspired me to talk about it. We're going to talk about the goals of scaling and root planning. This isn't going to be a lot of conversation about it because I really want to talk more about instrumentation, talk about providing the care for our patients during the time of COVID. We are all hoping that with the vaccination, we are coming to an end of COVID era and we can start to practice with our patients. I'm going to talk about the keys to success in ultrasonic and hand instrumentation. I'm going to introduce to you some really new innovative instruments that I have had the opportunity to use. These have really changed my ability to treat my patients and to really treat those patients who are way more advanced, because I'm able to really access and provide care to areas that maybe I didn't feel confident treating before. And then I'm going to show you just 2 real quick case studies that I treated in my office. So first, we're going to talk about periodontal disease and really what is periodontal disease. Periodontal disease is caused by a dysbiosis of periodontal microbia leading to alteration in host microbial crosstalk. And when you say it like that, you're like, my God, what does all that mean? What is this? So I'm going to break it down a little bit for you. Dr. Lowe used the word dysbiosis, and I thought, oh God, I am really reaching back to my head in microbiology. What was that? And really, dysbiosis is a microbial imbalance of the periodontal microbia. And it's leading to alteration in opponization, which prevents initiation of the complement system. And like, oh, wow, now we're really in microbiology. What does all that mean? Well, if you remember, the complement system is what plays a critical role in inflammation and the defense against bacterial infections. And opponization, let's talk about what that is. Opponization is really the ability for our body to label bacteria for destruction so that your body can phagocytize those bacteria in order to properly remove them and manage any bacterial infection. And so when we talk about it, so it's a little bit easier to understand when you say it's caused by a microbial imbalance of the periodontal microbia, leading to alterations in labeling bacteria for destruction, and inhibits the proper pathways for tissue inflammation, which in turn causes exacerbated destruction of healthy bone and tissue. So when we're talking about what is causing all this microbial imbalance, why do we have these patients where they come in and they have a mouthful of plaque and they have barely any inflammation and barely any destruction to the tissue? What are those things that we have to consider as hygienists that are causing this microbial imbalance? And we all know that there are some other factors that really play a role in them, including systemic disease, patient's genetics, patient compliance, patient behaviors, and dental treatment, or the treatment that we are providing for them. So as hygienists, there's only so much that we can do to control their periodontal disease. So let's talk about some of the things that we can control and some of the things that we cannot control as dental hygienists. As far as systemic diseases go, we can help our patients control systemic disease at some point, to a certain point. As far as systemic diseases like blood pressure, providing, patients going and seeking the proper medications that they need to treat systemic disease, but also educating our patients in the reactions that they might experience with the medications that they are taking. For instance, hyperplasia of gingival tissue when they're on high blood pressure medications, or dry mouth from high blood pressure medications, and making sure that we're helping our patients manage both of those side effects. The other thing is our patient compliance. Can we control our patient compliance? This maybe needed to be in the section of somewhat control, but I think that patient compliance can really be controlled through education, educating our patients on the disease and educating our patients on the disease process will really help them with compliance. Also, considering our patients' limitations when it comes to compliance. We have many things that can cause our patients' compliance to not be what we would expect it to be. May it be they're taking care of another family member who is sick, or they're working nights and their routine is off, or even I've noticed a lot of patients during this COVID when they're working from home, their routine is just off, and so their compliance is changing. And then our patient behaviors. Once again, can we control it? Maybe, maybe not. Probably it should be in the somewhat control, but as hygienists, we can provide education for our patients about the use of tobacco, how much they smoke, and educating our patients about the risk factor that their behaviors can really affect their gum disease. We all know that with grading and staging, smoking is one of the biggest factors that we take in account when we are grading our patients. Patients who have they smoke, but they smoke less than 10 cigarettes a day, we can easily grade them as a grade B. But if they smoke, it instantly puts them at a grade B. And then our smoking patients who are heavy smokers, it's going to put them at a grade C. So educating our patients about those risk factors and explaining to them their diagnosis and explaining to them how we come with that diagnosis, I think can really help improve their behaviors. And then the treatment that we provide for our patients will really help control their periodontal disease, in the fact that if we are providing the proper treatment for them and that is most comprehensive treatment for them, we are going to see the results that our patients really deserve as experienced hygienists and hygienists that are using all the tools that we have available to us. And then genetics. Is this something we can control? Unless you really believe in epigenetics, this is something that managing external factors that affect the way that genes are displayed, that's a whole nother lecture. But in reality, can we really control what our patients have and what genes they express? In reality, not as much as we would like. We can understand their genes through DNA, using the DNA and saying, okay, you're more susceptible to this, so these are the things that we're going to do to treat you. But we also have to know that we're providing the patients with the proper treatment that they need. And as dental hygienists, one of the greatest treatment modalities that we can do for our patients is scaling and root planing, providing the complete removal of the bacteria in order to remove all of the contaminated surface and in order to decrease the host response to the periodontal pathogens, which then once the inflammation improves, we can improve the access for our patients so they're able to clean their periodontal pockets. And so when we define what is successful treatment as far as scaling and root planing, we really need to talk about what are the success points that we need to do in order to consider our scaling or root planing successful. And some of the things that I really feel are important is the disruption of the bacterial biofilm to prevent the microbial imbalance that happens. Once bacteria is able to get established, and then bacteria that are known as those keystone pathogens get in there and really cause that imbalance and cause the destruction. And then as far as stopping our host inflammatory response, when we remove the bacteria, we're stopping that inflammatory response, we're allowing pockets to decrease, and we're able to allow our patient to improve the access to the areas to clean them, not only for them, but also for us. and then promote a long junctional epithelium attachment. I think that, this is a hard thing to be successful at, but as hygienists, this is really the best attachment that we can provide for them based on scaling root planning treatment. And Dr. Samlow, I thought he made a really impactful comment, and it was, we don't ever use the word cure the disease for a patient. We're always going to use the word manage for a patient. And so letting them know that all of the treatments that we do, they may be successful, but we are never going to truly cure our patients from periodontal disease. We're just going to simply help them manage the disease. So making sure that we're educating our patients on the importance of what the bacterial biofilm is that we are constantly trying to disrupt, and the importance of their part in disrupting that bacteria. I spend a lot of time educating my patients on the bacterial biofilm. I explain to them that we are, as soon as you come in, we are playing a time game. This is a game. As soon as you leave, this bacteria is coming back. It's instantly reattaching to the pelvic layer within 30 minutes of leaving our clinic. And letting them know that this bacteria continues to progress, and it creates a colony that is able to be very destructive. And explain to them that there is a timeline for that, and constantly disrupting it and giving us the ability to disrupt that below the gum line where they can't reach with some of their home care items. That happens within that 90 days. And this is why I teach my patients about the biofilm, to let them know that this is the reasoning why we have them come back every 3 months. Explain to them the reasoning of making sure that bacteria doesn't get to the destructive point and get to the point of that microbial imbalance. So ultrasonic scalers. As hygienists, I think a lot of us are feeling handicapped in the fact that we are unable to use our ultrasonics because we're fear of causing some cross-contamination. As dental hygienists, we are one of the highest at risk for developing COVID due to the physical proximity to the patients that we take care of, as also the risk of exposure because of the work that we do and the aerosols that we create. And so in my clinic, I have some things that we have implemented in order to keep ourselves safe and to manage the aerosols that are produced when I provide treatment for our patients. One of the things that we have in our clinic is, recently after COVID, my boss installed a bipolar ionization system. This is in our HVAC system, which provides the ability for our HVAC system to clear out areas like waiting rooms, hallways, sterilization areas. But other than that, our treatment rooms are sealed. We are able to shut the doors behind us when we go into our treatment rooms. So we're able to contain any of the aerosols that get produced during our treatments. We also have HEPA filters in our room. And if you are using a HEPA filter, one thing that I learned when I was researching during COVID is making sure that you don't put your HEPA filters behind you, because it's going to increase the airflow to move past you as a clinician. You're going to want to put your air filter either at the foot of the patient or next to you so that it pulls the air away from you. And then pre-procedural rinse. My patients all use a pre-procedural rinse. Currently, I am using Peroxol, and they squish with that for 60 seconds. And a little trick is I brought in Alexa, and I hope that doesn't get her talking, but I asked her to set a timer, and that way me and the patient can see the countdown for them using that rinse. When using hydrogen peroxide as a rinse, the virus is a very weak virus. Actually, it's very easily killed through oxidation, and hydrogen peroxide provides the oxidation. But it gets very foamy. And so letting them see the countdown of when they're using that mouth rinse is really good. And I usually tell them this is a very foamy mouthwash, it's going to happen, but making sure they rinse for the full 1 minute is very important. And then HVE suction. And like I said to you, I'm currently the US representative for the ErgoFinger. And with the ErgoFinger, it allows me to have complete HVE right at the source of where the aerosol is created. And then in my clinic, I work out of 2 rooms. I have 2 rooms to work out of. I switch between each room. And after every procedure that I do on my patients, the UV light is left to treat the room for up to 20 minutes. So ultrasonic scalers, we as hygienists, I know we all want to get back to using ultrasonic scalers. And once we implemented all of these precautions in our office, I went back to using my ultrasonic scaler. I have been using it for a few months now. The ultrasonic scaler is one of the highest risks for creating the most amount of aerosols. The reasoning for this is the particles are so fine and they're able to travel up such a far distance. That is why it's important that we consider the safety of using our ultrasonics. And using our ultrasonics during COVID, we found that through a study, using the HVE can be 90 to 98% effective in managing aerosols. And so it can really help with that cross-contamination. As dental hygienists, we don't really have the luxury of having a dental assistant next to us in order to do four-handed dentistry. Using a high volume evacuation can be very cumbersome, and it can be not very ergonomic for ourselves. So long-time risk of damage to ourselves is very important to consider. And so using those protections in order to protect ourselves and our patients from aerosol contamination, making sure we're using the proper PPE, our pre-procedure rinse, the HVE, and then a rubber dammer using just hand instrumentations, if you cannot put all of those safety factors in place. So the ErgoFinger, I'm just going to run through it really quick. Like I said, this is a product that I found back in Japan when I was teaching there. This product, I have invested my savings in it to bring it to the United States. I love this product because it's ergonomic. I'm able to keep it right next to the working space. As you can see in this video, using it, I am able to capture every aerosol coming off the ultrasonic tip because I'm able to keep it so close. The ErgoFinger has a tip that extends 360 degrees all the way around, and it also goes in and out, so the length of the instrument can be changed. The other thing is it meets the standards, the minimum requirements of having an 11 millimeter bore size hole that is required in order to be considered high volume evacuation. There's other products on the that are out there that are not necessarily considered that have those minimum requirements for being considered an HVE. The other thing with the ErgoFinger is we provide a lightweight hose that comes with a kit. But a lot of people are like, well, how do you hold a mirror? How do you use the ErgoFinger with a mirror? There is a learning curve when you're trying to use the ErgoFinger with a mirror, but the ErgoFinger can be used for the mirror for indirect vision. It can be used for retraction while holding the ErgoFinger and indirect redirecting light. There's webinars every month that are provided in order to provide those skills and help hygienists learn how to use it properly. So this course is about instrumentation, and so that's really what I want to talk about is scaling and root planning. And now that we're able to use some precautions to provide scaling or root planning for our patients, we can really change the way that we treat our patients by using some of the innovative instruments that are out there. Providing treatment for patients like this patient, he is a widow. He came to us for treatment. This is the second time he has been seeking treatment for his gum disease. But he's one of my case studies at the end of the course, so we will talk about that. So when I am providing scaling or root planning for our patients, every single patient, I follow the same sequence. And the reason why I follow a sequence is I make sure then I am consistent with every patient that I treat, and I can provide my patients with a routine that I am familiar with, and making sure that I follow through every patient. So first, with every single patient that I do for scaling or root planning in my perio clinic, I do not see the patient first. The patient is seen by my periodontist, who diagnoses the patient and then is the one that treatment plans, scaling, and root planning, and then the patient is put into my schedule. So most of the time, the first time I'm seeing my patients is usually at their first scaling and root planning appointment. Most of my patients come in and they have fear. They don't know what to expect. And so I have found that I can create a better relationship with my patient if, and only if, I provide scaling and root planning with local anesthesia. I tell my patients that if you are able to get through the portion of local anesthesia and I'm able to provide you with profound anesthesia, their experience is much more positive. And I think that it helps to start to create the positive, trusting relationship between you and your patients. I always use anesthesia on pockets that are greater than 5 millimeters when scaling root planning. If I have patients that are in my maintenance schedule and they have greater than 5 millimeters, I don't on standard use local anesthesia, but if they will let me, I will. I think local anesthesia can be one of the biggest advantages to providing care for our patients during scaling and root planning. And the biggest thing is also when you are trying to access a 9 millimeter probe depth and you insert that instrument all the way to the base of the pocket, the first thing the patient is going to do is pull their head back. And if the patient is doing that, there is no way that we are able to access the base of the pocket and remove the amount of calculus that needs to be provided. So after scaling or root planning, I do a ultrasonic gross debridement on my patient. But before I start to gross debride any of the calculus, because I was not the first one to see that patient, I use the Explorer. And I'm going to talk a little bit about the Explorer because I think it is the most important instrument in our kit. But when using gross debridement, I'm going to use a heavier tipped ultrasonic tip. The bigger the calculus pieces are and the more tenacious it is, the bigger the tip and the heavier tip I use. But I think it's very important for us to remember that we need to use the sufficient power that is required for that tip. Using a heavy tip at a light setting is going to only create burnished calculus, and it's not going to provide the care that we need in order to remove the calculus from the pocket. And when I teach my course in Japan, one thing that we do is the hygienists start collecting extracted teeth before I come. They are sterilized. And then we do scaling and root planning on those teeth outside of the mouth. And what it does is it gives my hygienist the ability to realize actually how much power is required to remove calculus from the tooth. And it also gives them ability to see what the ultrasonic actually does to the calculus. So if you ever want to do a cool experiment, ask your doctor to save some ultrasonic teeth and then do that. And you will realize really how much and how many strokes you have to go over that piece of calculus in order to remove it. So hand instrumentation. After using a gross debridement and removing calculus, the heavier deposits of calculus, I go back and I explore again. The Explorer, like I said, I'm going to talk a little bit about it. It is very important in order to give you the ability to understand what it is, where you're coming from and where you're going. And then sharp instruments. Sharp instruments are one of the most important things in order to provide the type of care that we need for our patients to prevent burnishing calculus and leaving calculus on the root surface of the tooth. Studies have shown that burnished calculus that is left on the root surface of the tooth will cause granulation in those areas opposite in the pocket where the burnished calculus is left. If you ever wonder why a pocket is not clearing up after you've performed scaling root planning, more than likely there is burnished calculus on the root surface, and that's what's causing the pocket to not clear up. And also hand instrumentation, and we're going to talk about these different instruments, using the specific instrument for each pocket, making sure to use those instruments that are meant for the mesial of the teeth, or using those instruments that are meant for the distal of those teeth. Although I'm not saying that we can't use instruments for other parts of the mouth, because I am a pro at adapting other instruments to other areas of the mouth that may not necessarily been meant to use for that. But making sure that we are adapting the working end and the blade to the root surface properly in order to prevent closing or opening the blade, which only can burnish calculus. And if you burnish calculus, like I said, removing it after it's burnished is much more difficult than removing it once it is before it's burnished. And then after a gross debridement, I go back and I fine scale with a lighter tipped ultrasonic tip, or at that point is when I turn down the power on my heavier ultrasonic tips. And what I like to do is use the ultrasonics to really flush the pockets out, flush the bacteria that I've disrupted off the root surface, flush the bacteria that's left at the base of the pocket, and flush any large pieces of calculus that have been removed by the hand instrumentation. You can use a fine tip or a thin tip ultrasonic tip for this, but many times I just turn down the power of my ultrasonic tip. Some studies have shown that using ultrasonic after hand instrumentation is going to give you a finer working or a smoother root surface. And so that is kind of why I've created the strategy that I have and the sequence that I follow during scaling or root planning. And then I provide my patients with home care instructions. Like I said, I am not the first one that gets to see my patient. And I also find that this is really the time that I get to be supportive to my patients and listen to the concerns they have and listen to the limitations that they may be experiencing and the reasons why they haven't been compliant up to this point as far as their home care. Compliance with patients can be influenced by many things, and dexterity is one of them. Flossing for most patients is nearly impossible. 95% of my patients in our perio clinic only use the water pick or proxy brushes, but it's more of my patients are using the water pick. I implemented using the water pick when I started in my clinic 7 years ago, and we see significant results in the use of the water pick. And if you can go to any of the sites for the water pick, you can see really the results and the studies that they've done on the impact that the water pick can provide. The water pick allows you to access areas up to 6 millimeters that using floss is not going to be able to do. And then I schedule my patients back and they come back for a reevaluation appointment. And those appointments are 4 weeks after their scaling or root planning appointment. And during those appointments, we take post-operative pictures, we reprobe, and then at that point, we talk about considerations for their perio maintenance appointments. And some of my patients, because we are a perio clinic, we do not return them back to their general practice right away. Those patients are sometimes kept in our clinic every 3 months for up to a year. And at that point, then we are going to evaluate the patients and determine if we will return them back to their general practice, or we're going to move forward to possibly providing more definitive care like osteoresective surgery or surgery with a laser. So now I get to talk about the instruments, my favorite. So accessing areas of the mouth can be very challenging. And I find that some of the most challenging areas to access are those deep, really narrow pockets. Most of those pockets can be found on like the facials of the canine or the facials of the lateral, the facials of 8 and 9. And I have a really cool case to show you at the end of this. But the deep, narrow pockets, my favorite ultrasonic tip for this is the left and right ultrasonic tip. And the reason why I like this tip is it comes in a heavier tip, and you can use the sufficient power in order to remove calculus. I think it's very adaptable. When you're using activated size on the areas of the calculus and the root surface, I think it's also one of the best for accessing furcation areas. You can access furcation areas even on the distal of the maxillary molars going in between the lingual and the buccal root in that area, and also the distal of the second molars behind 31 and number 18 to access those areas that you may have those bony defects from extraction of wisdom teeth or areas where the patient struggled to keep that area clean. Once again, I never use these instruments on the power that I need if the patients are not known. I think it creates a negative experience for patients, and it just gives them that constant anxiety. Are they going to feel something, or are they going to experience pain? The other ultrasonic tip that I use on a regular basis is the triple band. The triple bend is in every one of my kits, my perio maintenance kits, my scale and root plate kits. I use this instrument on every single patient. I like that it's very adaptable. I like the fact that it's a heavier tip. I have used the thin blades. I have used or the thin tips or the light tips, and I feel like when I'm using it, the patients feel like you're poking them. I think it acts more like a probe. And I think it causes a lot more sensitivity for patients. I have a lot more negative comments about the use of the ultrasonic tip when I use those fine tips. This is my personal opinion, but that's why I have used the triple bend in most of my patients. Once again, for scaling and root planing, profound anesthesia is very important in order to use the power that is needed in order to remove calculus. So, hand instrumentation. Hand instrumentation, I think, is one of the greatest skills as hygienists we have. I think that there are no other professionals that have the ability to provide care for our patients like hygienists. Hygienists, I think, handle instruments better than any other person. I know that we have spent the time to learn the different types of instruments, and that's what I hope to do today, is just go over some of those staple instruments that we have and then introduce you to some of my new favorite instruments that we have. So the success of hand instrumentation really depends on a couple factors. Instrument selection and the pocket depth. Using an instrument that has a long enough terminal shank that's able to access the base of the periodontal pockets, and make sure you're using the instruments that are able to adapt to those areas properly in order to sufficiently remove calculus. And then the type and the tenacity of the deposit. If you have a periodontal calculus that is heavy and it's tenacious, using instruments that are sharp, number one, will help you remove those heavy deposits and remove the disease cementums. And then those instruments and making sure that they are rigid enough. Instruments that don't flex when you try to apply lateral pressure to them in order to remove from the base of the pocket all the way to the top. And then root anatomy. I think as hygienists, it's very important that we always review our anatomy on our tooth anatomy, and using our knowledge to select instruments that can access those furcations, that can access the concavities, that can access all those possible things that are normal, but not in everyone. For example, for me, when I go to Japan, the enamel projection that you see many times on molars in Asians, understanding that this is something that can be normal, it can be there, but knowing that it's a possibility, and this may be a reason why we have pocket depths that have progressed in those areas. So knowing root anatomy and then knowing our specialized instruments in order to use them in those areas. And then experience. As dental hygienists, I believe that we improve. The more experience that we have, the more ability we have to provide the care that we need for our patients. And for me, as a dental hygienist, I feel like I've grown the most in the perio clinic. And it was within the first couple of years that I started in the perio clinic when I had the opportunity to visit the operating room, when my boss had the ability to open a flap. It gave me the ability to really understand how periodontal pockets are formed and the scooping effect that they have, and then understand what it is that periodontal surgery does in order to improve the success of periodontal disease. And it further gave me knowledge about that dental anatomy. It gave me knowledge about the way that bone loss occurs. So I would encourage you, if you have a periodontist that you refer to, I would encourage you to ask if you can shadow some surgeries. I think that you will understand really more about how calculus forms. I learned many times when he'd bring me into the operating room and show me a piece of calculus that I'd left, I thought to myself, my goodness, I don't really ever remember feeling calculus on the buccal surface of that molar. And it makes me focus on those areas when I'm providing scaling and root planning to make sure that I go back to those areas that I know that I have left calculus in at other times. So, and then once again, I'm going to go back to the instrument sharpness. Using instruments that are either not required to be sharp, that stay sharp over a course of time are, in my opinion, one of the best options. I don't have time to be sharpening instruments, and I know that I have faith in them working for me every time. The Black Diamond instruments that I bought last year, I have been using in my clinic since last year. Only recently have I decided that some of the curettes need to be replaced. But you have to remember that me, my doctor, another periodontist that works in the office, and 2 other hygienists are using that exact same kit for scaling root plannings. And we have a total of 3 of those in the office. So they are being reused routinely in the clinic, and they have held up to the test of time as far as staying sharp and being able to remove calculus sufficiently. So as dental hygienists, I think that we tend to have to work blind. I always think when I go into the surgeries where a doctor has laid a flap and he's looking at the root of the tooth, and I'm thinking, you are cheating. That is just not fair. You have the ability to access and see everything that is under the gum line, every little thing that's possibly left. And many times if he does surgery on my patients, I'm always like, did I leave calculus? How much calculus did you find? Because it's really important for me to kind of get that feedback and know, am I really using my Explorer to its best ability? And I think as hygienists, we don't have to work blind. I think that the Explorer provides us with what we need in order to create and understand what is going on below the gum line. So the Explorer, in my opinion, is like Braille to the blind. It gives us the feedback that we need to picture what is going on underneath the gum line. The Explorer can be used to detect disease cementum. It helps us determine how deep the calculus, so we can provide the right instrument selection in order to access the calculus. It can help you determine whether or not the root surface is thoroughly cleaned, and if it's smooth and all of the disease cement has been removed. It can help you differentiate between the anatomy of the tooth. Is it decay, or is it poor restorations? And also determine the furcation involvement. And understanding and knowing furcation involvement is going to allow you to select those instruments that are needed. And using the Explorer in the proper way and allowing the Explorer to give you the feedback that you need by the vibrations coming through the instrument, and learning to picture what is going on with use of the Explorer is very important. In my courses in Japan, I teach, once again, using the Explorer with my hygienists, and they explore the teeth that have been extracted. And I have explored the teeth with their eyes closed. And then I ask them to explore the exact same area with our eyes open so that they can learn what it is that they're feeling and help develop that skill of understanding what they're feeling when they're using their Explorer. I use the ODU 1112 Explorer. I've been using that Explorer since I graduated hygiene school. It's a universal diagnostic instrument. It has a mirror image on both ends. You can adapt it into very deep pockets. Like I said, it can be used to detect location of deposits in the pockets. And I use it, like I said, every time before I start ultrasonic and every time after, and before I switch between each of my steps. So I kind of know where I'm coming, where I'm going, and where I need to go when I'm providing scaling and root planning for my patients. And in my opinion, I have found that the ODU 1112, it is across many providers and manufacturers of instruments. And I think the thinner, the better. I think you get more vibrations coming up through the instrument, and I think that it gives you more information. The LM is one of my favorite Explorers. The tip of it is very, very thin, and I feel that it gives you some of the best vibrations when using it. So periodontal maintenance. I provide periodontal maintenance and scaling and root planning in my office, and every periodontal maintenance appointment, I have a specific kit of instruments that I have been using for years. My kit is very small. I do not use a lot of instruments. I have specialized in using certain instruments often so that I can be proficient in using these. And these are the ones that I use every day. LM has a really neat probe that I like. It has a small, very small ball at the very end of it. And I believe it allows you to enter pockets that maybe are tighter or harder to enter other than other probes. It's very thin, so it allows me to access those pockets, especially those deep, narrow ones. And in a perio clinic, it's very important for me to identify all the areas where a patient may have pocketing, so I can really identify an area that may be needing treatment right away before letting it advance. So in my kit, I use the WHO probe by LM. I use the 1112 ErgoFinger, the ODU. I have the Sharpjack, the Barnhart, and the Nebraska. And the handle that I have chosen for the LM, they do have a series of them, but the ErgoSense handle is my favorite. They did studies on this handle, and they did studies on the fatigue that you feel between a series of different manufacturers and their hand instruments. And this was one that they determined has very good outcome for hygienists who tend to use it. So the Nebraska, this actually is an instrument that I just recently added to my case. And the reason why I did is because I think that it really provides that the narrow tip to provide you to get to remove stains in between contact areas. I hate stain just as much as any other hygienist, but using the Nebraska has given me the ability to really access those areas and scale the stain in between the areas. I like to use it for the mesial concavity on the first premolars. And I will use it in shallow pockets in the premolars. I don't tend to use it in the posteriors just because of the straight shank. You can adapt it to the pockets, making sure that you're initiating the cutting edge properly in order to actually remove calculus and not burnishing it. The other instrument that I use, the Sharpjack. The Sharpjack comes in many different forms and many different manufacturers. I have used it in every single manufacturer almost known. And I really just love the adaptability of this instrument. I've been known to do a full scaling root planing with this instrument that has 5mm probe depths and do an entire mouth with just this one instrument. It's a universal instrument. I love it for the lower anteriors. I use it supragingivally, I use it subgingivally, and I think my favorite spot for it is really the line angles of the molars. You're able to adapt the instrument around the line angles and make sure that you're able to clean those areas. I use it in the posterior, I use it in the anterior. It's definitely the instrument that I could do an entire day with just this instrument. And then recently I switched just from the Barnhart to the Columbia. And the reason I did that was because the Barnhart actually has a longer terminal shank than the Columbia 1314. And in a perio clinic, when you're accessing pockets that tend to be a little bit deeper, and I'm dealing with patients who have 6, 7, 8mm, and I'm routinely maintaining them, this is why I chose to use the Barnhart over the Columbia 1314. It is also a really good instrument to use it as a scoop to access the stain on the linguals of the mandibular anteriors. So scaling a root planning kit. So in addition to my perio maintenance kits, the instruments that I just talked about, I have these staple instruments. And these staple instruments include the 1314 Gracie curette, the 1112 Gracie curette, the 1516 Gracie curette, and the 1718 Gracie curette. So let's talk about the differences between these two instruments. The 1314 and the 1718. These are both these instruments are meant for the distal of the posterior teeth. And I use the 1516 for pockets ranging between 5 and 6mm in the posterior teeth. When I start to access pockets that are deeper than 6mm or 9mm, then I'm going to switch over to my 1718. And to understand the true difference between the 1718 and the 1314 is we have to look at the terminal length, the terminal shank length. And the terminal shank length on the 1718 is going to be a little bit longer. It's going to provide you a little bit more length in order to access those deeper pockets. The other thing that it has is it has a sharper angle. And this sharper angle allows you to access the distal of those the second molars, those deeper distal pockets that you're trying to get, even on 14 or number 3 that you're trying to access. This sharper angle gives you better adaptability to it. Now, like you see, so the difference in that terminal shank, there's a slight difference, but it does provide that much more access to the areas of the pocket. In the Columbia 1314 and in the 1718 in the Gracies, I use the Black Diamond Instruments by LM, and the LM to get into Black Diamonds for the 1718, they only came in the mini. And so I purchased the 1718s. I was a little bit concerned at first that they were the mini instruments, that I wouldn't be able to scale areas like I'd want to because they were minis, but actually I have found that I like them very much. I like the fact that they are minis. I feel like I work in smaller strokes and more definitive motions in order to remove calculus. But I've also found with a mini, I'm able to use them even in the anteriors when maybe I wouldn't have done that because the pockets are thinner. And so I really like getting that difference between the standard length and the mini length in the 1314 and the 1718. Same with the 1112 and the 1516. The 1516 is also that mini curette. The tip is going to be just a little bit smaller. The 1516, I like it because, like I said, I've been using it actually in the interior. This is a case that I did on a patient. He had 9mm probe depths on canines and his lateral, and I was able to adapt that 1516. He kind of had the way that he had the root surface alignment, I was able to adapt the tip to the root surface and really scale those areas and get them clean. And that mini blade allowed me the access that I needed in order to get to there. And as you can see, that terminal shank is so much longer, you're able to reach those deeper pockets. And then I just recently introduced the lateral hoe and the posterior hoe to my kit. And the reason why I did that is we maintain a lot of patients on the second molars who have deep pockets from having wisdom teeth extracted later in their life where they weren't able to reestablish bone. And I like the LM posterior hoe for that. It allows me to manage those pockets and access those pockets when I might have struggled a little bit more, or when I feel like I can't use my 1718 mini to get on those areas. The lateral hoe has become one of my favorite instruments. I almost feel like I want to introduce this to my maintenance kit. But the lateral hoe, I use it for the molars on the buccal surfaces of the root surfaces in those really narrow pockets where they're difficult to reach. I also use this lateral hoe in that same case to access the really deep pocket on that canine in order to get to the base of the pocket. And it allowed me to I used that initially to remove some of the more tenacious hard calculus, and then I was able to enter and use I used that 1516 on that root surface to clean it. And so the lateral hoe has just been a nice addition to it. I think that we as hygienists don't tend to use the hoes to our advantage, but they are really great instruments to access different areas that the curettes are not meant for, especially the buccal and the lingual of teeth. Sometimes I feel like the curettes can adapt to those areas. Their angulation isn't right, especially if you have a teeth that is lingual, has the lingual tilt, and you're really trying to get into the pocket. It's difficult to access with a curette. So furcations, we all know that furcations as hygienists is one of the toughest areas to maintain. And we have class 1 furcations. That's when you have no more than 3 millimeters where you can enter the furcation of the pocket. These pockets are usually able to be treated if you can remove the calculus from that area, allow that area to heal and allow the tissue to heal. And if the patient's able to access it with proper home care, those tend to can stay stable. Now, you also need to consider, does the patient have occlusal trauma? That's also encouraging the furcations to develop. Class 2 furcations. Class 2, I think, are like your last chance ditch effort to manage a tooth that's developing a furcation. I think if you have a class 2 furcation in patient, you should highly consider referring these out to a periodontist. The success rate of managing class 2 furcations through osseous resective surgery is higher when you enter and you're able to access them before they become a true class 3 furcation. Class 3 furcations can be very difficult to manage. The success rate of putting new bone in a class 3 furcation and getting it to take is very difficult. It's difficult for it to maintain long-term prognosis, and so treating those furcations early is really going to help prevent the progression of those furcations. I know I'm running into time, so I don't have much more. But I want to talk about these new instruments that I have had the opportunity to use. These instruments that I got sent from Planmeca, I was so excited when I was able to get them because, as you know, furcation areas are typically very tight areas. Using that walking motion with an instrument is very difficult. So using an instrument that you can use different motions in is really advantageous. And so one of the instruments that I was able to use are these instruments that I was given by Planmeca. And these are all mini furcation files that you can use, and they are diamond plated. So there's thousands of working cutting blades on these instruments, and they allow you to access very limited areas. And so some of these instruments that I have been using, let's see if it, okay, so these are diamond coated files. They're used for cleaning deep concave root surface areas. And this is one of the ones that I started using. I like this one for a really tight class 2, or the development of when a class 3 is not quite through and through, but it's very difficult to access. It's a very fine instrument. It's very narrow, and you can access it just like you can a furcation probe. And then these are more rigid. They're a little bit thicker. You're going to be able to use this on a more profound class 2 furcation and areas where you have heavier calculus. I use this instrument is very fine. It's very adaptable. You can use it in pretty much any area and adapt it into these areas that you need to. I love it. As you see, you can go in the top of the furcation area and then down the sides of the tooth. And then these are the heavier, more rigid furcation files. These are used for more debridement. So if the area is big enough for me to access it, I will use this first. It's more for that rigid, heavier calculus. And then I will go back with that previous instrument that I showed you that's just a little bit finer and has a finer tip and allows you to access that area. So this is using this instrument, and I have used this instrument so much since I added it to my kit. And then I have to say, my favorite instrument that I have been sent by Planmeca is this instrument. Imagine if you were able to scale areas where your probe can reach. And this instrument allows you and gives you the ability to do that. This instrument is very thin. It is coated with diamonds, and you can walk through a pocket just like you can in a probe, removing calculus. I like to use this on areas where I know that the cementum is contaminated and I'm just trying to remove that contaminated cementum. I've used this on the distal of the second molars. I've used this in tight periodontal pockets. I've used this almost anywhere. I love this instrument. If I could put it in every single one of my instrument kits, I would. There's times when I'm like, oh, Dane, I need that instrument. And due to COVID, I don't go out of the room and go get it. but looking at adding some more of these to the kits and putting more of these in my rooms so I'm able to use it. And then, so this just demonstrates using it along the areas of the teeth. Sorry that these videos are not muted. I thought I had done that. So you get to hear a little bit of my house of what's going on behind closed doors. But see how you can access the second of the distal of the second molars, cleaning those areas. I have a lot of patients that are sent to our clinic for us to manage the distal of the second molars. Dr. Miyamoto will do surgery on them, and then I continue to help them manage those patients. One of the other instruments that I have is this instrument. What I like about it is it's also a very fine instrument. It's able to access those very small furcation areas and clean areas that you are not able to provide that up and down working stroke. It's more like a scooping motion. And it's a very fine instrument. What I also found that I like this instrument for is removing stain on the lingual of the maxillary anteriors or mandibular anteriors. It's awesome. It gets in the tiny little grooves of the teeth and removes any of those areas that just drive you crazy. And if you're OCD like me, you don't like to leave them. So real quick, I'm going to show you some case studies that I've recently used some of these new instruments on. This is one case that we had to our clinic. I showed you the picture of him earlier. As you can see, these deep, 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 narrow pockets on the anterior of this tooth. This was a 9 millimeter, and actually removing the calculus, I think it was a 10 millimeter when I got done. I scaled this area, and before I dismissed the patient, I took a follow-up x-ray to make sure that I had completely removed that calculus and allowed, so that I made sure that this area was going to heal for this patient. And I was able to access this pocket with this little instrument. This was the one that I said to you, this is called, they call it the Mestis, MESDIS instrument. And it allows you to access these deep, narrow pockets. And so this was before, and it was 9 millimeters. It was very difficult to reach. He also was put on an antibiotic after this appointment. He had, before I started, he had a ton of exudate coming from all the pockets. So as you can see, beginning, after pictures. We had great results with this. I was confident in the way that I was able to scale this patient. I was confident in the ability to access the pockets that were really deep. And I was very happy with the results that I got on this patient once he returned. So I feel like I achieved my goal. The goal of scaling root planing, I feel like I achieved the goal for this patient. These were his before pictures. 9 millimeter probe depths in these areas. And actually what I found is once I started removing calculus, if you go and you look at his post-operative probe depths, there are areas that are actually deeper than they were before I performed scaling root planing. And that's only because we removed calculus. And once you remove the calculus, when you reprobe, you're able to get deeper into the pockets. This is another patient. She is my patient that was pregnant. As soon as she got pregnant, she developed her gum disease just accelerated very, very quickly. So we put her in a monthly maintenance schedule. We saw her every single month during her pregnancy. She had had scaling and root planing done by her previous dentist. So giving me the ability to go back and do scaling and root planing at that time was not an option. But I was able to have her come in, and every time she came in for a 1 month appointment, I would choose a spot, I would anesthetize it, and I would scale that area. And through those appointments, we saw a significant improvement in her case. Her periodontal disease started to stabilize. And then once she had her son, we were able to stretch her appointments out to back to 3 months. But the issue that we found was just this lower anterior. We struggled with constant inflammation in that area, and I struggled with accessing it. She was very sore and tender in that area, and her tissue was very thin. So using an instrument that was big and bulky in that area, I was very nervous about it because I was very worried that I would not be able to access it without causing damage to that tissue. And so these are the most recent pictures that we took of her. I used this instrument, the one I told you about. I was able to access those tiny little tight areas. I did use a lateral hoe in a couple of those areas. But like you see, so these are the results going from before the first time we saw her, managing her through her pregnancy. And then the last one is finally, I was finally able, it was 2 years out since she had scaling or root planing, I was able to do scaling or root planing. So as hygienists, I know we're really scared to try new things, but we can all break new habits. Old dogs can be taught new tricks. We can be innovative and use new instruments. So don't be afraid to try them. Don't be afraid to invest a little bit of money in some of these products that are out there and enter them into your new kit, because they are amazing and giving you the ability to treat areas that you didn't think that you could treat before. Planmeca has offered to give a discount code. You'll get 25% off of your order if you use the code, if you're interested in investing in some of these instruments. And like I said, I highly recommend, if there was anyone, if you had to choose one of them, I would choose this one that's just like the probe that has thousands of cutting edges. But I highly recommend any of those new innovative instruments that I talked about at the end. They really have given me confidence to tackle scaling root planing cases that I didn't think I could. So I'm sorry I went over a little bit, but I'd love to answer some questions if you guys have any questions. I know that Lydia is going to come back on here and we can talk about a little bit more.
Hi, great. Thank you very much. We do have a couple questions and we'll be cognizant of everyone's time. The first question was, how much time do you get for two cues of SRP and LBR?
So with 2 quads of scaling or root planing, my boss allows me to choose what it is that I would like. He will schedule me for 2 hours. Many times I go back and I look at the x-rays or I look at the probe depths of the patients and I ask them to adjust it. Either I ask them to adjust it down or I adjust it up. So on standard, I get scheduled for 2 hours.
Thank you. The next question is, do you feel that you can actually get to the base of a 9mm pocket?
Absolutely.
I would not be too hard on yourself because flap surgery would be indicated.
Yes, I routinely treat 9mm probe depths like I showed in my case study that I showed you. And that patient recently went to surgery. He had surgery done and Dr. Miyamoto actually laid a flap and used the laser and accessed the pocket and was able to identify that I had successfully removed the calculus from the pocket.
And we had one other question. What does PMAT stand for?
Perio maintenance.
Great.
Appointment. And so in my clinic, I perform perio maintenance appointments only. I don't do prophy appointments.
Great. And I have posted the AGD code and the link to the CE survey in the chat. It looks like, the commentary, you are exceptionally lucky to get a 2-hour SRP appointment or cycle. So I want to thank Becki once again for presenting for Planmeca. She's a great advocate of education, and I want to thank all the attendees. I noticed through the link that we have a lot of familiar names from the hygiene community, and on behalf of Planmeca, I thank you for using Planmeca as a source of education. Yes, the webinar will be available as a recording. You will receive that in the email with the AGD code, the link to the survey, as well as a reminder of this great code at shop.planmecausa.com, 25% off your entire order, and that is only available until the end of the year. Thank you very much, everyone, and have a good afternoon. Stay safe.
Bye.